Hello, this is your Brain on Drug Psychiatry podcast. This is a punk rock psychiatrist. And continuing on, not doing the videos anymore. They just seem to not be working for me. So it's audio only, but once again, slides are available for download on the website, www.punkrockpsychiatrist.com. So my whole depression series is in one slideshow. I've got over 300 slides, and it's probably going to end up being around 30 episodes for all those. But you can download them all now. But I'm kind of updating them as I go, and so everything that we've already covered, I haven't changed. But the things that I may get to in the future are there potentially could be some additions and subtractions from those. And so if you're looking at the ones in the future, there may be some change. But continuing on with the adverse effects of the antidepressants, and the big ones we're dedicating whole episodes to. So QT prolongation, that's a big issue, and it covers beyond antidepressants, so that got a whole episode. Sexual side effects, we did a whole episode. Last episode talked about the black box warning for suicidality, and this will be the last episode where I cover a side effect as an entire episode, and it's serotonin syndrome. All right. After this, I'm going to have one episode where I summarize kind of the rest of the side effects, and then we'll go through the SSRIs and then on through all the second generation antidepressants. So I'm excited to talk about serotonin toxicity, otherwise known as serotonin syndrome. I think serotonin toxicity is actually a more precise term, but serotonin syndrome is what you're always going to hear. All right. So what we're going to talk about what the symptoms of this are, how to diagnose it, what medications could contribute to it, which ones likely do not contribute. And this is going to be, I think this is going to be something that a lot of people learn something from. The list of medications that don't contribute are frequently found on lists of medications that do. So I think that's going to be a really good one. And then I'm going to round it all off with differential diagnosis. And so there's a couple other syndromes that resemble serotonin toxicity. And so we're going to kind of go over those and see how they're different. All right. So let's get started. Serotonin syndrome. I've broken up the symptoms into a few different categories, and I'm kind of highlighted some of these. And the ones I'm highlighting are the ones that are these are almost like pathognomonic for serotonin syndrome. Like if you're seeing this, your light should really be going off that we're talking about serotonin syndrome. All right. So the first category are hyperkinesia symptoms. So what does that mean? Kinesia is movement. Hyper means more. So hyperkinesia means we're having an increase in movements. And we're talking kind of about bodily movements, right? So anxiety, tremor, an agitated delirium, disorientation. So this is a major way that the patients are going to present, and especially if they're around friends and family that are going to see them, and they're going to be acting strange, right? They're not going to be acting like themselves, and this is going to be they're going to appear very ill. They're not going to maybe know where they are. They're going to be saying some things that don't make sense. They're going to be asking questions like they've been, almost like they've been hitting their head or something. Like, what are they talking about? Or maybe they're not responsive, but they're like very agitated and anxious. So they're in this hyperkinetic state. Okay. So that is one way that they might be picked up on, and because the patient is not always, they may be so out of it that they don't even realize that there's something wrong. And so it's those around them that kind of see, oh my gosh, this person is obviously not well. We need to get them to the emergency department, right? So that's the first category of symptoms that we see. Next, you see autonomic instability. What does that mean? This basically means that your vital signs are off. And pretty much all your vital signs can be affected by serotonin toxicity. You can get rapid heart rate, increased blood pressure, increased breathing, your temperature goes up, you get a fever, you're sweating. So your vitals are off. And they're in kind of they're, I mean, I wouldn't use the word hyperkinetic to describe it, but they're hyper, right? Tachycardia means rapid heart rate, so like more beats of the heart. Tachypnea means more breathing. Hypertension means your blood pressure is increased. Hyperthermia means your increased temperature in your body, right? So we've got this increased movement, and also our vital signs are kind of elevated as well. So we've got this elevation of behaviors and elevation of vital signs. And then we've got some other stuff that's kind of elevated, right? Um, our GI system is going wacky, right? We're having, if you listen to bowel sounds, we're having more bowel sounds, so hyperactive bowel sounds. So there's a lot of hyperkinetic, hypertension, hyperthermia, hyperactive bowel sounds, right? A lot of extra stuff. So you've got more bowel sounds, and what does that mean? That means that your bowels are moving more than normal. And what's going to happen when you have that, right? You're going to have nausea, vomiting, diarrhea, right? Your bowels are moving quicker, okay? And then also sialorrhea, that's drooling, right? That's excessive production of saliva. So you're also like your GI system is kind of going haywire, right? And then mydriasis, that's when you get enlargement of your pupils. So if you're doing a physical exam on these patients, typically we're going to see enlarged pupils, as opposed to some disorders you see. Oh, sorry, decreased size. I messed that up. Myopia is. I always think of it's weird because myopia sounds like open, but it really means closed. So myopia means decreased size, and mydriasis means increase. Oh, so I was right. Mydriasis, increased pupil size. Um, so, I mean, that's another kind of hyper looking thing. So you have an enlargement. So everything is up. More bowel sounds, more saliva, bigger pupils. You're vomiting and diarrhea, more gastric movement. Vital signs are up. You're moving, right? Everything's agitated in this state. And this is going to be important because we're going to contrast this with other things that the patient could be experiencing. I mean, it could just appear that they have, an infection, right? I mean, you could have vital signs like this, or your bowel sounds and so forth, right? But what we're really looking at, everything is up, everything's going. And the next category is when we're really seeing stuff that tells us that we've got serotonin syndrome going on. When we look at the neuromuscular area, all right, so what is that? That's, your neurons, they connect to your muscles and they cause your muscles to tense up or relax, okay? And so once again, we've got kind of a hyper situation going on here. So muscle rigidity, that means more muscle tension, and more likely to be seen in the lower extremity, but could be seen other places. So you've got an increase in muscle tone, right? And hypertonia, right? Again, with another hyper, okay? And then the reflexes, right? I think this is something that, people that remember this from med school and so forth, you think of the hyperreflexia. We've got the massive reflexes. You tap on the patellar and there's a huge movement, much more than you would expect, okay? Now, it's possible that could be masked by the hypertonia. So if it's not there, that doesn't necessarily mean that they don't have this. And then clonus. This is a huge one, okay? Think about clonus. It's when you do that. Remember the physical exam finding where you're doing your neuro exam and you take the patient's foot and you put it into the dorsiflexion position and then into, or sorry, the plantar flexion position and then the dorsiflexion position. And for those of you that don't know what that is, plantar flexion is whenever you like kind of point your toes, like if you were to go up on your tippy toes, and then dorsiflexion. Dorso means back, so that means when it's moved, when you move the foot back the opposite direction. All right. And when we check for clonus in a physical exam, you're going to quickly put the foot down and then up. Okay. And then you're going to feel and watch. Now, I remember when I learned, I've never seen clonus in a physical exam finding. And so I've had to find videos so I could see like what does it actually look like. But I think when I was learning this, what I was thinking was I would push this and I would feel and clonus. And if you think about what that word means, it kind of conjures to mind seizures, right? So one type of seizure are tonic clonic. There's lots of different types of seizures, but a tonic clonic seizure is the one where you kind of have that jerky motion. What most people think of when they think of seizures, right? They have that jerky motion where it's like muscles are tensing and coming back and back and back, jerk, 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 jerk. So clonus, tonic, clonic, the clonus comes from that. So clonus is that rapid back and forth movement. The tonic means, the increased tone, but the clonus is this kind of rapid back and forth movement. And so you can induce clonus in the patient by doing that physical exam finding where you point the foot, pull the foot back, right? Plantar flexion, dorsiflexion. And, it might be mild where you feel it and you can kind of feel it pushing against you. But typically when we see clonus in a serotonin toxicity situation, you could just let go of the foot and just watch it just move and just watch it kind of wriggle like that, right? Back and forth, back and forth, back and forth. All right. So those are our symptoms of serotonin toxicity. All right. That's what you're going to see on a patient that has this. And the time frame that we're looking at is 6 to 24 hours since they had some sort of change to their medication. Because as the name suggests, serotonin toxicity, we have too much serotonergic activity going on. And you're really only going to see this when we're taking a medication that affects serotonin. And those are the medications we're discussing. And that's why we're talking about the side effect. So, as opposed to some of the other syndromes, this one actually happens fairly quickly. So 6 to 24 hours after there was a medication change. So that either means that we started them on a serotonergic medication, or we maybe increased the dose, or we added another medication that has serotonergic activity. And so we're going to see if they're going to get serotonin toxicity, it's going to happen soon. Within a day, it's going to happen. I've read or heard talks, and I don't know how valid this is, that there's cases where patients are getting this, but it's a very mild case, and they're coming to your appointment, and maybe they've got a little bit of a tremor, maybe they've got a little bit of anxiety, but and maybe if you did a physical exam, there'd be a slight increase in their reflexes. I don't really think about it that way. I think of this as like an emergency. This is something where the patient appears quite ill. Um, I I just I'm not on board with this idea of the mild case of serotonin syndrome where someone can basically walk and talk and go through their lives with a tiny bit of serotonin toxicity. I wonder if that's talk about just from people that don't want us using these medications at all. So It's not something that's on my radar, not something that I think about, not something I've learned about. This idea that you could have a very mild case of serotonin toxicity where it's not an emergency, but I bring it up just to kind of say that it's out there. All right. So the next thing that I want to discuss. So we've gone over all the symptoms, and we're going to talk about the symptoms a little more. But we're going to talk about how to diagnose it. And actually, there's this thing out there called the Hunter criteria, where they've made it pretty straightforward. Um, there's You have to meet one of these five things. And so there's five different ways that you could diagnose serotonin syndrome through a combination of the symptoms we've already discussed, where you could actually make this diagnosis. And so that's what we're going to do now. I'm going to talk through what those are and how you would see that. All right. So the first one is only a single symptom. The second, third, and fourth ways are combinations of two symptoms. And the last one, you have to have three symptoms because they're less severe. All right. So the first one, it's only one symptom: spontaneous clonus. Okay. So you remember how I talked about how we're inducing clonus by moving the foot in the physical exam finding? Somebody could have that clonus without you even doing that. You're inducing it by, this is an upper motor neuron issue. Same thing, reflexes are also upper motor neuron. If they have clonus without you even touching the patient, it's just like they're jerking, their foot's jerking, or I mean, it doesn't have to be the foot. You could have clonus anywhere in any muscle group. But it's just, that's the easiest place to test for it, and it's the easiest place to see it. So if somebody's got clonus just on its own, that's serotonin toxicity.
And, there's some other conditions where you're going to see clonus, but you're pretty much going to have a suspicion of what it's going to be based on other symptoms that the patient's displaying. So, some other indications or some other disorders where you might see clonus: cerebral palsy, multiple sclerosis. So, I mean, those are conditions where the patient already has those diagnoses. And so that would make sense if you saw that in those. Spinal cord damage, of course, if somebody presented with other signs of spinal cord damage, and some other things, stroke and hepatic encephalopathy. So, I mean, you've got some laboratory values and some other signs that are going to lead you towards those things. In pregnant women, preeclampsia, eclampsia, or some other conditions, and then seizures as well. So there are some other conditions where you'd see clonus. So the fact that they say that just having spontaneous clonus is, you can diagnose serotonin syndrome from that alone. You really have to, I mean, you have to rule out some of these other things as well, but you're going to have that suspicion. So it's not really going to be able to pretend to be something else so easily.
Now, next, we've got the inducible clonus. Okay, so the one where we moved the foot and then that induced the clonus. And so you've got that, and you have either agitation or diaphoresis, excess sweating. So if you've got agitation or excess sweating and you were able to induce clonus, that's another way. That's the second way that you could diagnose serotonin toxicity. The next one is similar. Um, It also involves clonus plus agitation or diaphoresis. But this time, we're not talking about inducible clonus, we're talking about ocular clonus. I believe this is also called like opsoclonus or something like that. Um, this is clonus of the eye muscles. So, like I said, you can have clonus anywhere. So, if they now, if you'll recall, there's another related symptom called nystagmus, right? So, which is also involves movements of the eyes. So, what is the difference? How do you differentiate between nystagmus and ocular clonus? Well, it's the pattern. All right. So with nystagmus, typically we're staying on the same plane. right? It's either going to go side to side or up and down. And often it's whenever you have the patient track your finger and they follow your finger and then they have nystagmus. And there's some medications that can cause it. And, this is something much more, in the wheelhouse of neurology. They're seeing this in neurological conditions that are not, this is the, I would say serotonin toxicity is actually like a neurological, it's a toxicology disorder. It's a neurology disorder. It's not really a psychiatric disorder. Okay. And as a psychiatrist, you're not really going to see it, right? Because think about it. You may be the cause of it, right? Because you're the one that gave them the medication that caused it, but you're not the one that finds it, and you're not the one that does something about it. You're not the one that diagnoses it, but it's because you're the one that causes it. I think it's really important to know these things. All right. So, right, because the person's going to come into the emergency room and then they're going to end up on the internal medicine service while they're getting treatment. And then, they could have overdosed on their meds. That could be why this happened. Maybe they took more than they were supposed to because they were attempting suicide. So they may end up on the psychiatric service after internal medicine, or they're probably at least going to throw a consult your way. And you're going to, at least rule out that you don't think this was suicide attempt. This was a medication reaction. And they're going to want to know, what should we send this patient home on? So that's where psychiatry is going to get involved. You're going to have to figure out what to do with this patient's medications since they had this reaction. And we'll talk about that in a second. All right. But even though you're not really doing all these exams, I really think it's important for all physicians to know about all medical things, because it's important. You never know what you're going to see. You never know if you're going to be the one. I've caught issues that have nothing to do with psychiatry because I'm just informed of those disorders. And sometimes patients will come to you with psychiatric symptoms, but it's caused by something that's not psychiatric. And so you need to know about this stuff, because you don't want to just like have the blinders on and be like, okay, I only see psychiatry, or I only see cardiology, or I only see surgery. You have to see the whole picture, the whole patient. And so that's why this is a really interesting topic. So back to ocular clonus. So we were talking about nystagmus, where this is where the eyes jerk one way and slowly track back. Jerk and slowly track back. So it's a fast, slow movement, a fast movement over and a slow movement back. And we're going to, with nystagmus, we're going to see it kind of going on the same plane. So it's either going to be going, out to the right and back to the left, out to the right, back to the left, or up and then down, up and then down. But with ocular clonus, it's a fast, fast movement, and it doesn't follow this kind of plane. It just jerk, 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 jerk. It could be going up, down, right, left, diagonal the other way, left, right. It's kind of going all over the place, and it's just jerk, 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 jerk. So that's how you would differentiate nystagmus from ocular clonus. So, getting back to the Hunter criteria. So if we've got the ocular clonus, or inducible clonus plus agitation or diaphoresis, that's diagnostic for serotonin toxicity. So those are 2 and 3. What's 4? So 4 is now we've got the hyperreflexia, the overreactive reflexes. So there are other things that can cause this, but if you've got the hyperreflexia and a tremor, that's diagnostic for serotonin syndrome. Okay. And then lastly, hypertonia. Remember, increased muscle tone. Hypertonia plus a temperature over 38 Celsius, so a fever, plus either inducible clonus or ocular clonus. So this could be, you had the clonus, it's not spontaneous, it's either inducible or it's ocular, and you didn't have the agitation or the diaphoresis, but you've got a fever and hypertonia, that will be the diagnosis as well. So with that last one, you actually need three. All right. So now we've kind of talked about what the patient looks like, how to diagnose it, what causes it. All right. And this is where I think a lot of the misinformation is. And I think this is where those of you that are familiar with the topics I've already discussed, this is where you're going to learn something new. This is the real juice. All right. Um, there's this I think people get overly cautious sometimes and they just say anything serotonergic, but it's really not. Remember when we talked about our neuroreceptors and we discussed that there are all these different serotonin receptors, um, 5-HT1A, 1D, 2A, 2C, 3, 4, 5, 6, 7, right? We've got all these serotonin receptors, and serotonin will agonize or kind of turn on all of them. And then we have certain medications that will block certain serotonin receptors or will only agonize some receptors but not others, right? So with serotonin syndrome, we're primarily focused on 5-HT2A. If we're messing with other receptors and we're not touching 5-HT2A, then that medication should not be a risk for serotonin syndrome. All right. So, what does light up 5-HT2A? What medications do affect that? I think, if you've listened to the episodes up to this point, you can probably name a lot of them. And there's probably several that you weren't aware of. And that's why we're going to go through these, because not all of them are psychiatric meds. And that's where things get interesting. Okay. So, first, meds that affect serotonin metabolism, right? The MAOI inhibitors, what do? Monoamine oxidase inhibitors. They block the enzyme that destroys serotonin. So they basically increase the amount of serotonin that you've got floating around inside your brain and so forth, right? So if those increase the amount of serotonin, then there's more serotonin to act on 5-HT2A, and therefore you could be at risk of serotonin toxicity. All right. And remember when we talked about MAOIs, that not just the MAOIs that we use for um, depression are to blame here. Remember linezolid, the the antibiotic. It's an MAOI. Methylene blue, used for methylglobinaemia, it's an MAOI. And then Syrian rue, which is an herbal that I'm not really. I need to. I wish I'd looked this up before the episode. Maybe I'll add some of this stuff to the end. Um, but yeah, Syrian rue actually is an MAOI, and so someone might be taking that. So those are the. I mean, the medication category, and then methylene blue, linezolid, and Syrian rue.
Okay, so I went ahead and looked up what Syrian rue was, and I read a little bit more about it so I could provide that information. And from what I could find, it doesn't seem like it's something that's commonly consumed. It's native to kind of the Mediterranean areas, North Africa, Middle East, those type of, which, it's called Syrian rue, so, that's Syria, but it seems like it's used often in folk medicine superstitions, but more like burned as incense and not consumed terribly often. So I'm not sure how much it's actually consumed in any cultures at this time. It's actually an invasive species in many countries and many states in the United States. You have to eradicate it. It's been known to poison cattle. So it's a dangerous substance, and so it's not something that you're going to run across very often. But I include it here just because it's something that could be, is an MAOI, and it's, something to know about. And then also regarding linezolid, I had read that cases of serotonin syndrome with linezolid combined with other serotonergic medications is actually pretty low at around 3%. Though, I mean, I still wouldn't want to take any kind of chance with that, but perhaps, that it's not as potent as some of the other MAOIs.
So these are our biggest concern. Because if you remember when we talked about MAOIs, we discussed that you cannot combine them with any other serotonergic medication because it's a risk of serotonin toxicity. That's the reason. We can combine all the other meds that we're going to talk about that can increase your risk of serotonin toxicity can be combined, but none of them can be combined with an MAOI. Remember, within 14 days, because even though the MAOIs have a very short half-life, they permanently change. They permanently inhibit this enzyme, and it takes 14 days to create more of that enzyme. Okay, and then so we think about if we're going to start, say we're going to start fluoxetine. Well, if we have to wait 14 days to start the fluoxetine because we have to wait for our brains to make more MAO, more monoamine oxidase. And then we also have to do it the opposite direction. So if we're changing from fluoxetine to MAOIs, we also wait. Now remember, we only have to wait about 1 to 2 weeks with most medications, but because fluoxetine has such a long half-life and its metabolite has such a long half-life, we actually have to wait 4 to 5 weeks. And vortioxetine has a longer half-life. We have to wait 3 weeks. All right. And that's because we need to make sure that that drug is out of our system. So I think people might get confused when it's like, when it says don't take within 14 days of an MAOI, we mean on both sides and for different reasons. So if we're changing from a serotonergic medication to MAOI, we need to wait until that medication has metabolized out of our system. We need to have 3 to 5 half-lives before that medication is gone. Different meds have different half-lives. On average, their half-lives are a day or two, and we have to wait about 1 to 2 weeks to be safe. And then we have to wait the 2 weeks from the MAOI over to those medications because it takes 2 weeks for our brains to make more MAO so that we don't, because it's permanently inhibited until we can get rid of it out of our brains. So that's why the MAOIs are so important to understand, because you cannot combine them with these other meds. All right. So now let's talk about those other meds. So next category are your SRIs, your serotonin reuptake inhibitors. Now this is going to include SSRIs and SNRIs, but it also encompasses a lot of other meds that you probably don't think of as serotonin reuptake inhibitors. Several of your synthetic opiates, such as tramadol, methadone, meperidine, and fentanyl, they in addition to being mu agonists, they your mu opioid receptor agonists, they also have serotonin reuptake inhibition they do both. Okay, it's kind of like how an SNRI both blocks the reuptake of serotonin and norepinephrine. Tramadol is not just a mu agonist, it's also an SRI. All right, so that's important to know. And this actually brings up something I alluded to when I was talking about when I first brought up this topic when we talked about MAOIs. There was the case of, and I wanted to look this up and I forgot, but I believe her last name was Zion. It was like Casey Zion or something Zion, and it was in New York. And this is around the early 90s. And I believe she was on an MAOI, or maybe it may have been a tricyclic, and they gave her meperidine Demerol because she presented to the ER agitated. So I think she might have had serotonin intoxication. Just, I don't know if she had attempted suicide. I wish I could. I'm going to look this up and tell you at the end of the episode. But she was actually given Demerol and meperidine, which would make the condition worse. And it was it was a resident who had not had much sleep, and then they said, "Oh, this is because he hadn't had enough rest," and so the whole hours restrictions that interns and residents have to follow. And attending physicians like myself do not have to have hours restrictions. And I mean, when you really look through the case, like her father was a lawyer, and sometimes people they get overzealous because like they've had this loss, this horrible things happen, they need to blame somebody, they blame the resident, they blame the hours restrictions, when in fact this error likely would have happened without the hours restrictions, because they probably just didn't notice or remember or know this information. It wasn't that they were so tired. Not that I think that I'm thankful for the hours restrictions. I benefited from those when I went through my training. Um, it would have. I certainly think that people practice better medicine. I mean, I've often seen them compare not having enough sleep to being intoxicated on alcohol, and yet we're okay with people not having enough sleep. So I think it was a good result, but if that result had happened prior, it actually wouldn't have changed anything. And so I just think it's an interesting point. All of you out there that are listening that have hours restrictions, you have psychiatry to thank for that. It's our meds that caused the problem that was blamed. So, and it definitely was the Demerol. I have to look up what the other med is that she was taking.
All right, so I went ahead and did some more digging so I could, validate what I had told you, and I got pretty much everything right that I had just said a second ago. But the MAOI she was taking was actually phenelzine, so she was on an MAOI for depression. It was actually 1984, so a little bit before the early 90s, and the result was in 1989. It was actually the state of New York that implemented the requirements for less hours for residents and interns. And it was later in 2003 that it was adopted throughout the entire country. And, the thing is, this was on court TV. This was a huge trial. These doctors were, there was a civil case against them, it was a criminal case. It went on for years and years. And ultimately, they were cleared. And when you look at the case, it's like this reaction was not well known back in 1984, and they had actually consulted with the family doctor, the one that had prescribed the MAOI before giving the Demerol. And so even though they may not have been well rested, they consulted with a physician that knew the patient well. So I think what came out of it was good, but this was not necessarily a good illustration of the medical system gone bad. There's probably a lot of other cases where um, the hours restrictions led to mistakes. In this particular case, the one that actually made all the difference, it doesn't appear that the lack of sleep was the issue. There were just several other issues that I already discussed. And the other thing was her name was Libby Zion, not Casey Zion. So let's continue on.
So we're moving through the SRIs. So we had SNRIs, SSRIs, some of the mu agonists are also SRIs. So dextromethorphan, the cough medicine, and chlorpheniramine and brompheniramine, which are histamine blockers, but they're all three of those are also have SRIs capabilities. And the important thing about these three meds is that these are three meds that the patient may be buying in cough and cold medication off the shelf. And it's not, when they're buying it, it doesn't say, oh, this is chlorpheniramine. It'll just say, to help you with, take it nighttime for your cold symptoms. Because and the whole point of it is to like make them sleepy so it's easy to sleep. It's not necessarily, if they have some allergy symptoms that are the cause of their cough and cold, then perhaps. But typically, when patients are taking cough and cold medication, it's not that they're having allergies. And this is a reason why I don't think it's a great idea to bundle several different medications into one thing that they take when you're taking maybe uh, guaifenesin, dextromethorphan, chlorpheniramine. Um, what else might be in there? Uh, Tylenol, ibuprofen. You'll often see like four different things in one. And so this is the danger. If you're giving someone an MAOI, you've got to make sure don't take cough and cold medication without telling me. I will give you the cough and cold medication that does not contain dextromethorphan, chlorpheniramine, or brompheniramine. And I know a lot of you are probably thinking to yourself, chlorpheniramine, brompheniramine. I've never really even heard of those, right? Because I think when we think about the first generation antihistamines, we think about diphenhydramine, Benadryl, right? Well, and doxylamine is another one, uh, often used for sleep. But chlorpheniramine and brompheniramine, although not something that I prescribe or in my medications, they are found. If you look at, I did this one time. I looked at every single cold medication in the store, and because we had a big problem with cough medicine abuse where I was working, and I was trying to find out how many of these meds contained dextromethorphan because it can be abused. It's like robotripping, stuff like that, right? And so I noticed that a lot of them also had chlorpheniramine and brompheniramine in them, and it was very educational. I was like, wow, there's meds in here that I didn't even know what it was at the time. I was like, oh, these are histamine blockers, huh? Well, they're also SRIs, and they're commonly out there, and your patients may be on them. And if you give them an MAOI, you could be then they're getting the other medication just on their own. So that I think that's a reason why people might be afraid to give patients MAOIs, and it's a reason to be cautious. You've got to kind of be aware of all these different meds that they might be able to get. Okay, so what are some more SRIs? Fenfluramine. It's used to be used as a weight loss medication, but it was associated with some valvular issues, taken off the market, but it's still used rarely for a couple of different seizure disorders. Sibutramine is another weight loss medication, and that one I think has been completely taken off the market, but it's an SRI. Cocaine's actually an SNDRI. It's the only one I'm aware of. It blocks reuptake of serotonin, norepinephrine, and dopamine, and quite strongly. So it's very potent. And cocaine's a Schedule II controlled substance. It's which means that it does have medical use. Is a topical eye surgery numbing medication. I don't know how often it's used. I'm not an ophthalmologist. Next, St. John's wort. We're going to talk about St. John's wort in a lot of detail uh, at the in our depression series, because St. John's wort actually is a herbal medication that patients could be buying off the counter. Here's another one that's an SSRI, and it's an alternative to if you got these patients that they just there are patients out there that they're okay with taking an herbal because it's natural, but they're not okay with taking the chemical, even though it's the same thing. So if they're like, I'm not going to take that Prozac, but I'll take St. John's wort. Well, we'll talk about what if that's helpful and why and what the differences are and what to be aware of. I can certainly say that I don't want someone taking a psychoactive substance that I'm not really aware of. And there's a lot of drug interactions with St. John's wort. It's kind of dirty. There's a safe way to do it, if for the right patient, but another one to be worried about for serotonin toxicity. Next, metoclopramide. Now that's Reglan. It's a D2 blocking nausea medication, but it's got some SRI function in it. And then we've got a couple of antipsychotics on the list. So ziprasidone, which is Geodon, and lumateperone, which is a new medication, Caplyta. A lot of the antipsychotics affect serotonin receptors. Most of the second generations block 5-HT2C. Some of them, lurazidone's one, it agonizes 5-HT7, but we're only concerned with 5-HT2A agonism, and that's happening with ziprasidone and lumateperone in particular. So those are two antipsychotics to be aware of. And then the tricyclics. I hadn't mentioned those yet. You're probably thinking, well, we mentioned MAOIs, SSRIs, SNRIs. Why not the tricyclics? Because it's not all of them. Now, if you remember our tricyclic talk, some of the tricyclics don't affect serotonin hardly at all. They're mostly affecting norepinephrine. And I've even heard that you could combine the ones that are not the serotonergic tricyclics with MAOIs. Like, I wouldn't do it, but I suppose if you had a really sick population and there was a reason to, and you were monitoring them carefully, because the thing is, even the ones that mostly affect norepinephrine at higher doses, they are serotonin reuptake inhibition as well. But the ones that we should be the most vigilant on, there's really only three that are serotonergic: amitriptyline, imipramine, and clomipramine. So the other ones, not really a big concern for serotonin toxicity. Those are the three. All right, so those are all the SRIs. Let's talk about SRAs. It's like, oh, what's an SRA? I mean, we talked about serotonin reuptake inhibition. What is SRA? So that's a serotonin releasing agent. What does that mean? So when we talked about SRIs, they block the reuptake transporter pump, right? You've got the serotonin out in the presynaptic cleft, and then it's often getting recycled back up into the nerve terminal so that it's not going to be used to interact with the receptors on the nerve on the other side of the cleft. Um, so it gets reuptake, and then when you block that reuptake inhibition, it basically makes more serotonin available in that cleft, right? That's how an SRI works. But an SRA actually releases, so you have serotonin stored in your nerve terminal, and it gets released through the pump, and then it gets sucked back in through the pump, right? These releasing agents actually cause more serotonin to be released from its storage vesicles. So it's stored in these little storage containment inside the cell, and naturally these get released, but there's a few medications that actually stimulate this release. Fenfluramine is one of them, but once again, not a medication that is hardly ever used. Carbamazepine, which is used for bipolar disorder, not so much anymore. Maybe seizure disorders if someone's been on it for a long time, but not one that we typically would start with a new patient. And then ecstasy, MDMA. All right. So if you've ever taken or heard about it, and people that take ecstasy, it causes massive euphoria. And the reason for that is it causes the release of serotonin. So, because I think some people think, why is these other serotonin medications not cause this euphoria, but something like ecstasy does? Well, this is why. It's a difference in potency, but it actually has a different mechanism. It's a serotonin releasing agent. And this is why when people use ecstasy, they feel so crummy for like around 3 days after they've used it. Because what happens is it just takes all this, you've got all this serotonin like waiting to be released. Your brain is trying to be in homeostasis, it's trying to be in balance and release it at the appropriate time. Well, NMDA says, I don't give a crap when you release this. We're releasing all of it. Every bit of serotonin that you have in your system is out the door right now. Bathe my brain in it. And that's what causes the significant euphoria. But then that's what causes that 3 days of withdrawal, because it takes your brain time to make more serotonin. Like your brain has to take some component parts and put them together to make serotonin. And if you use it all up, and it all gets flushed and it all gets recycled and it's just all gone, then you don't have any left. So you have to wait to make it. And that's why a lot of drugs have their withdrawal, but that's why ecstasy is particularly significant. So that kind of leads us into the next category of serotonergic medications. That'd be the serotonin precursors. So these are the components that make up serotonin, right? L-tryptophan is the main one. So you need L-tryptophan, which is a amino acid. So it's kind of like a component of protein, and it's what people think of that's in turkey and stuff like that. But the reason why people get tired on Thanksgiving, but that's because they eat a lot, not because of the trip. You would need massive amounts of tryptophan. So, but tryptophan is actually the precursor to serotonin. And remember, serotonin 5-HTP, 5-hydroxy tryptophan. So it's actually in the name of serotonin. It's full like chemical name. And so if you take L-tryptophan or 5-HTP, a 5-HTP versus 5-HT, these are precursors of 5-HT, serotonin. Um, and those are, once again, things that people can find on in the store on their own. And then the 5-HT2A agonist. These are your hallucinogenic medications: LSD, psilocybin, magic mushrooms, mescaline, peyote. And so this is one where it's like theoretically there should be a risk, but there's I'm unable to find any case reports of it actually happening, serotonin syndrome, from these illicit substances. And then the last one would be the anti-epileptic drugs, the AEDs. So they can actually affect serotonin. So this is valproic acid, Depakote, lamotrigine, Lamictal, and gabapentin, Neurontin. All right. So those are used for seizures, but also they're mood stabilizers. And then another thing is have caution with strong CYP inhibition. So the CYP enzymes, the P450, 2D6, 3A4, those type of things. If you have a medication that inhibits those enzymes, so say all tricyclics depend on 2D6. So if you take a 2D6 inhibitor, say fluoxetine, you increase the levels of that even further. And you increase your likelihood that, maybe you took a normal, maybe you were taking your normal amitriptyline, and you didn't have a change in your dose of amitriptyline. You didn't add another serotonergic medication, but you added a drug that was a 2D6 inhibitor, say Wellbutrin. It's a 2D6 inhibitor, but it's not a serotonergic medication. It increases the levels of that amitriptyline. That could put you into serotonin toxicity. So that's just another kind of indirect med change, that you're not actually changing the serotonin med, but you're still increasing its levels. And then next is a really important one. I want to go through the list of medications that aren't a risk. And if you look this up, you will see these meds on lists, and people will say, I've seen it. But what I think is probably happening is maybe they took a 2D6 inhibitor, and that's what caused it. It wasn't the addition of one of these meds. Maybe they took something maybe they, took some L-tryptophan or some St. John's wort or some dextromethorphan, right? Maybe they took one of these type of meds, and that's what threw them in to serotonin toxicity. And so you may think, we started a triptan, which is our 5-HT1B and D agonist, and that's on lists, and that could cause it. Well, it doesn't affect 2A. It was probably something else. It was not the triptan. Triptans do not cause serotonin syndrome. These are neurology's meds. Look at any good neurology source, and they say that this does not happen. So this is a myth, and we're busting it. Triptans don't cause serotonin toxicity. They affect serotonin, but not 2A. Next, antiemetics. So these are anti-nausea medications. I'm not including metoclopramide because that's an SRI, but I'm talking about the Cetrons, ondansetron, granisetron. They're 5-HT3 antagonists. They antagonize, and they don't affect 2A. They don't cause serotonin syndrome, but you will see them on lists. Mirtazapine and trazodone, they actually block the 2A receptor. Trazodone has some reuptake inhibition. Mirtazapine has no reuptake inhibition. Mirtazapine does not increase serotonin, does not increase activity at 2A. It blocks it. And trazodone, even though it has a tiny bit of increased serotonin reuptake inhibition, it blocks the receptor that causes serotonin toxicity. So these are not a concern. So, don't worry about combining these meds. Bupropion, I see it on lists. It's an NDRI, doesn't affect serotonin. Buspirone, it's a 5-HT1A agonist, and now we have Gepirone, which is also a 5-HT1A agonist. They don't affect 2A. They don't cause serotonin toxicity. Methylphenidate and amphetamine, once again, NDRIs. They have little to no effect on serotonin. Morphine analogs, And remember, we talked about some of the synthetic opiates, and one of these days we'll go into opiates. We'll have an opiate lecture, and we'll talk about the difference between different types of opiates, synthetic versus analogs of morphine versus hybrids, etc. But the synthetic ones I mentioned before, tramadol, methadone, meperidine, fentanyl, they have SRI function. Morphine analogs, the ones that are not synthetic, they don't. Percocet, hydrocodone, hydromorphone, these don't cause serotonin syndrome. All right. So if you're going to give someone an opiate, give them one that's not the kind. If we have a patient with serotonin toxicity, and then cyclobenzaprine, it's a TCA or it's a TC. It's a tricyclic. It's not a tricyclic antidepressant, but it's a TC. But remember, not all tricyclics affect serotonin. Cyclobenzaprine's one. It mostly affects norepinephrine, um, as well as some other things, but it doesn't affect serotonin, so it's not a risk. And then lithium, we see all the other mood stabilizers on the list. Lithium works differently, does not cause serotonin syndrome. All right, so triptans, the citrons, mirtazapine, trazodone, bupropion, buspirone, methylphenidate, amphetamines, morphine analogs, cyclobenzaprine, lithium. You'll see them on lists. Don't worry about these. And if you're, and the thing is, you remember how I said don't combine any of these medications that can cause it with MAOI, but you can combine the ones that are not MAOIs. Now, does that increase the risk of serotonin toxicity? Yes, but this is a very rare disorder, very rare. I wouldn't not give somebody something for that reason. And then on top of that, you have people that maybe don't want to give, maybe they're taking fluoxetine and they're taking a triptan and they're like, oh, I don't want to add a third one. And it's like, there's no third one. Triptans aren't one. All right. So they just have the fluoxetine. You're adding a second one. And maybe they're adding trazodone. Oh, they're on a triptan and now I'm adding trazodone. And it's like, triptans don't cause it. Trazodone doesn't cause it. Prozac by itself could cause it. An increase in your Prozac dose, that could cause it. You don't have to combine medications to cause serotonin toxicity. It can just be caused by one of them. And it can be caused by a relatively low dose. And you could have somebody that overdosed on 15 pill bottles and they don't get serotonin toxicity. So, what throws some patient into toxicity and another one not? You could have someone on 4 serotonergic medications. You could even have them on MAOI and it's not causing serotonin toxicity. And you've got somebody else on a therapeutic dose of a regular old SSRI and they get serotonin toxicity. There's no rhyme or reason. Certainly there's an increased risk with increased dose and an increased risk with increased number of medications and an increased risk with taking an MAOI. But that doesn't necessarily mean that this patient's going to get it and this one's not. And, this is something to be aware of, but it's not the only one that's a hard and fast rule of do not do this is, I've said this like 15 times, you're probably sick of it, is the MAOI. That's the one you can't combine. The rest of them, be aware, maybe brief the patient if you want, tell them, we're giving you 2 agents. There's a slightly increased risk, but it's super rare. And if it happens, please come to the hospital or whatever, but it's just not something that you should be overly concerned about. But if, you've got a patient with the symptoms of it, you want to look at their med list, right? All right. And then finishing this off, what do we do if they actually get it? What's the treatment, right? I mean, if it's a psychiatrist, you're obviously not going to be treating this, but stop the offending agents. So anything that you think, I probably want to stop almost everything they're taking, unless it's something they really, really need that's like preventing them from having a heart attack or something like that. But if someone's really ill, you often hold their medications just in general, even ones that are not affecting it, because we don't want anything affecting our treatment. So stop the offending agents and then provide supportive care. And you just got to wait for it to go away. Cooling blankets because they're overheated, benzodiazepines to help calm them down. Maybe that helps with that muscle tension because they're, more relaxed. We're in this hyperkinetic state, give them the benzodiazepines so they slow down. And remember, in that case, they gave the patient Demerol to calm her down, and that just made things worse because it added to the problem because they didn't really know what they were dealing with. She was agitated. They wanted to give her something to calm her down. They thought she might have been in pain. And then cyproheptadine, I mentioned this before. It's a 5-HT2A antagonist. Uh, Sometimes that's used as an antidote, but I don't know how well it works. I don't even know if it's done that much anymore. And so, lastly, let's talk about the differential. Okay. So, what else kind of could resemble serotonin toxicity? So, there's three things: neuroleptic malignant syndrome, MAOI, hypertensive crisis, and anticholinergic toxidrome. So, and in each of these cases, your serotonergic medication could be causing one of these other things, right? Uh, you may not be aware of this, but neuroleptic malignant syndrome, which is typically caused by dopamine blocking medications, the antipsychotics, can be caused by the serotonergic medications as well. Not very common, but they can cause it. And then, if you remember, ziprasidone and lumateperone, they can cause both. They could cause neuro because they're antipsychotics and they block five or agonize 5-HT2A, so they could cause serotonin syndrome and neuroleptic malignant syndrome very easily. And so, and then MAOIs, if you have an MAOI, it could be hypertensive crisis or it could be a serotonin toxicity. Which one is it? Right. And then anticholinergic toxidrome. The TCAs have a lot of anticholinergic powers. We've talked in depth about that. Paroxetine does. Um, or they could be on two medications, one that's an anticholinergic medication and one that's a serotonergic medication, and they're having this syndrome. Is it serotonin syndrome or is it anticholinergic, toxidrome, right? So how do we tell these apart? I think the main takeaway is look at the Hunter criteria. None of these other toxidromes have those Hunter criteria. And you can't really diagnose serotonin syndrome definitively if they don't meet one of those five criteria. So that should make things easier just in and of itself. But I think when you're taking a test and you can't, you can't really look this stuff up, maybe you don't remember Hunter criteria. What are some of the definitive things about each of these other syndromes? Neuroleptic malignant syndrome. So it's got some similarities. We've got the autonomic instability, the 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 hyperthermia, the fever is a big. You will always have that pretty much with NMS, neuroleptic malignant syndrome. But you can also have it with serotonin syndrome. So you've got some things that are similar, right? But remember how we have the hyperkinesia and the hyperreflexia with serotonin syndrome? You actually have the opposite with NMS, bradykinesia. So they're slowed. So they could still be delirious, but instead of an agitated delirium, it's more of a stuporous delirium. Uh, maybe you can't even tell that they're delirious because they just seem sedated and sleepy, and maybe you think that they just took too much of their antipsychotic, and it's some of their sedating medications. Well, it may be that they have bradykinesia associated with NMS, especially if they've got a fever. If they've got a fever, they're slowed down, and then their reflexes are just almost not there at all. And then the other big one is the lead pipe rigidity in all muscle groups. Now you can get lead pipe rigidity in Parkinson's and NMS. That's really where you see it. You also get the cogwheeling in Parkinson's, but for NMS, it's lead pipe rigidity. And there's one other type of muscle rigidity I want to talk about, which is the knife clasp rigidity. So what's the difference between lead pipe rigidity, cogwheel rigidity, and knife clasp rigidity? So lead pipe, think of it, I mean, it's like their limb is a lead pipe. If you're bending their arm, it moves slowly. Like it's slow to move it. It's very firm. And then if you try to move it back the other direction, it's still slow. So it just does it. They're tense in all directions, and so it's like bending a lead pipe. All right, just slow. That's lead pipe rigidity. Cogwheeling is whenever you try to move the limb and it's resistant, and then it jerks, and then it's resistant, and then it jerks, and then it's resistant. And so it's like the cogwheel, right? Jerk resistance, jerk resistance, jerk resistance. And then the knife clasp is a kind of like one big cogwheel. So it's like resistance, and then it goes, and then it goes like all the way, right? And then if you move it back, it's resistant, and then it goes all the way. That's seen with spinal cord injury. The other type are seen in Parkinson's, and lead pipe is also seen in NMS. So thinking NMS, when I see bradykinesia, bradyreflexia, hyperthermia, lead pipe rigidity, those are the big things. And remember, two of those are you can have the hypertonia and the hyperthermia with serotonin syndrome, and then a lot of the medications overlap. So this is really the one that you could be in the most risk of confusing the two. But the bradykinesia and the bradyreflexia versus hyperkinesia and hyperreflexia, those are the big differences. And these are more likely to be seen with the dopamine blocking medications, so they can be seen with serotonin medications as well. You also get elevated CK, typically more than 1,000 with NMS. And then remember the time frame of the med change. With serotonin syndrome, it's a pretty fast response, 6 to 24 hours. But with NMS, the change is seen it can take up to 10 days, and the average is about 1 to 3 days. Now, could it be a little sooner? Sure. But if you've got one that it's lasted a little bit, it's taken a little bit longer since the change was put into place before the symptoms started, that's going to point you more in that NMS direction. All right. Moving on to the next one, MAOI hypertensive crisis. Okay. So this is obviously only going to be with an MAOI. So if you're taking one of the other serotonin medications, you're not worried about this. But if you're taking an MAOI, is it serotonin syndrome or is it MAOI hypertensive crisis? And you can have hypertension in either one. But typically the hypertension in MAOI hypertensive crisis is a lot worse. So it's severe hypertension. And to the point where they're having headaches, neck stiffness, photophobia. So just like very dangerously high, severe hypertension. And then you can still have the sweating, nausea, and vomiting. But also importantly, those Hunter criteria, you're not getting the hyperkinesia, you're not getting the hyperreflexia, you're not getting clonus, you're not getting hypertonia. So that's the other thing. If you go through your Hunter criteria and they don't have it, then let's look at MAOI hypertensive crisis. All right, if they were taking an MAOI, and in this case, it's only an MAOI that could cause that. And then lastly, the anticholinergic toxidrome. This one is not as similar as the other ones are. And remember, serotonin syndrome is kind of it's more wet. Like you're drooling, you're salivating, your bowel sounds are in motion, you're vomiting, you're diarrhea. But with anticholinergic toxidrome, you're dry to the touch. You're hot but dry. So it's the hot is there either way, but you're dry. You're not sweating, right? Remember, there's a lot of sweating with serotonin toxicity. You're dry. Your mucous membranes are dry. Your bowel sounds are decreased or absent. So you think about those anticholinergic side effects we talked about with TCAs. Those are kind of severe here. And then you have normal muscle tone. Your reflexes, your muscle tone not affected at all. So once again, if you use your Hunter criteria, you're not going to run into a problem. But I think if you also think about how these different processes work, these symptoms make sense. All right. So I hope you guys learned a lot about serotonin toxicity. And if you were reticent about prescribing certain medications together, maybe you're less worried about that now. And maybe if you were concerned about, what to do. Say the other thing is what happens if the patient was hospitalized with this and now you're seeing them again and you still want to treat what's going on with them, right? So I think knowing what meds can and cannot cause it, maybe you go with Wellbutrin, because this person's obviously sensitive to getting serotonin syndrome. We want to give them an antidepressant, and we want to use one that's not going to put them at risk for this again. And even though Wellbutrin shows up in those lists, don't be worried about it. So I think that's where, you think, okay, I had a patient that had this, but I don't want it to happen again. What med could I use? Maybe I use the antipsychotic. Maybe I had them on some Ziprasidone. So maybe I use some Lorazepam instead because it doesn't have the 5-HT2A agonism. And so I think that's where you can really use the information from this is, not being afraid to combine certain meds, but being afraid with the MAOIs and then kind of knowing which meds to not be worried about. So if you need to change someone's meds up that had this happen, know what to do about it, right? Because we still want to care for our patients. We don't want to like not treat them because, oh, well, you can get this disorder, so I'm not going to give you anything. No, no, no. Let's look and see and figure out. This is why, I want to go through these mechanisms of action. Like, how do these things work? And if you know how things work, then you can know how to tinker with things and pick the a better choice next time, right? So I want to thank you for joining me. I hope you enjoyed the episode. Like, subscribe, follow, tell your friends, and I will see you next time.
And so we go on with our lives. We know the truth, but prefer lies. Lies are simple, simple is bliss. Why go against tradition when we can?